Greetings. In this session, we will delve into the practical aspects of groin hernia repairs. We will begin with a detailed step-by-step of the standard open indirect inguinal hernia repair. Following that, we will cover the modifications for direct hernia repair and critical decision-making required for femoral hernias, incarcerated or strangulated hernias, and sliding hernias, and discuss pediatric patients. The goal is to provide you with the techniques you will practice in the skills lab and then continue with in the operating room. Remember and review the anatomy of the inguinal canal. Operative technique involves attention to detail, including patient positioning, anesthesia, incision placement, and dissection of the layers. The cord structures need to be identified, and indirect and direct hernias diagnosed and managed. The posterior wall is closed, and then the wound is closed. The supine position is used for inguinal hernia procedures. Wash your hands and explain the preparation procedure to the patient. Ask the patient to remove jewelry and change into a gown. Confirm the correct surgical site. If needed, remove hair with clippers. Clean the skin with soap and water if needed before prepping the operative site using antiseptic solution. Start skin antiseptic preparation at the incision site and move outward in a circular motion. Do not go back over the same area with a dirty swab or sponge. Allow the skin to dry completely. Do not let the patient touch the prepped area. Place sterile drapes after the skin is dry. Expose enough of the inguinal region for safe access while keeping the rest of the patient covered. Before the incision, meticulous maintenance of aseptic technique is the primary defense against postoperative wound infection. Secondly, hemostasis is crucial throughout the procedure. A blood-filled field obscures anatomy and increases the risk of infection and hematoma formation. The procedure includes two essential steps, regardless of the specific type of inguinal hernia. 1. Management of the peritoneal sac. You must rule out an indirect sac by mobilizing the cord structures. If a sac is found within the cord, it requires mobilization and high ligation. 2. Repair of the facial defect involves reinforcing the weakened posterior wall of the inguinal canal. The aim is a tension-free repair, which may be achieved with mesh. The principle is to reapproximate strong tissues to provide a durable barrier. Excessive tension leads to pain and recurrence. Let's begin the step-by-step breakdown. Step 1. Open the inguinal canal. Incision. Make a skin incision approximately 1 to 2 centimeters above and parallel to the inguinal ligament. A practical tip is to mark the location and length of this incision with a pen before prepping and draping the patient. For adequate exposure, the incision should be slightly longer than the length of the inguinal canal. In this diagram, the lighter pen marking indicates the skin incision parallel to the inguinal ligament. The horizontal incision demonstrated in the image is more cosmetic, but this incision is not used for local blocks as it requires more traction to expose the external oblique. Dissection. Sharply incise through the subcutaneous tissue and the superficial fascia, Scarpa's fascia. You will usually encounter veins, the superficial epigastric veins. Large veins should be ligated to prevent postoperative hematoma. Smaller vessels can be cauterized. Key maneuver. Once the skin and subcutaneous tissue are opened, identify the white fibers of the external oblique aponeurosis. After you have identified the external oblique, it should be incised in the direction of its fibers from the external ring towards the internal ring. As you open this layer, the first structure you must identify and protect is the ilioinguinal nerve, which often lies just beneath the external oblique. Failure to protect this nerve is a leading cause of chronic postoperative groin pain. Step 2. Mobilize the cord structures. The easiest place to begin mobilizing the spermatic cord is near the pubic tubercle. Place a small piece of gauze or a latex drain, like a glove drain, around the cord structures for gentle retraction. This provides excellent control. Using gentle, blunt dissection, free the cord from the surrounding tissues. You will encounter the cremasteric muscle. This muscle layer should be opened longitudinally or divided to fully expose the cord. If you divide it, ensure you achieve hemostasis as it can be quite vascular. You will frequently find a yellow, lobulated mass of extraperitoneal fat lying alongside the cord. This is often called a cord lipoma. It is not a true tumor but can mimic a hernia sac. It is essential to peel this lipoma away from the cord in a distal to proximal direction, ligate it proximally, and remove it. Leaving it behind can lead to the patient feeling a persistent bulge postoperatively. Step 3. To identify the sac, you search the cord. If one is identified, the hernia is indirect. Remember, in an indirect hernia, the sac is located anteromedially to the spermatic cord. Separate the peritoneal sac from the cord structures using blunt dissection, such as with a gauze-covered finger or a peanut sponge. Always dissect from distal to proximal. The goal is to free the sac completely right up to the deep inguinal ring. This is essential for achieving a true high ligation. If the hernia sac extends distal to the external ring into the scrotum, an inguinoscrotal hernia, do not attempt to free the entire distal sac from the cord structures. The sac is intimately adherent to the cord vessels and the vas deferens in the scrotum. Aggressive dissection carries a high risk of injury to the testicular vasculature, leading to testicular atrophy. Step 5. Visibly and digitally examine the sac. It is crucial to reduce any abdominal contents found in the sac back into the peritoneal cavity. Then, carefully inspect the inside of the sac. Run your finger around its interior wall. Look for a sliding hernia, where a portion of the sac wall is actually made up of an intra-abdominal organ, most commonly the cecum on the right or the sigmoid colon on the left. Recognizing this prevents a catastrophic injury later when you try to ligate the sac and the intra-abdominal organ. Step 6. Perform high ligation of the sac. After ensuring the sac is empty, twist it on itself. This maneuver ensures no viscera is caught at the neck. Place a transfixion suture at the very base of the twisted sac, as high as you can visualize, right at the level of the internal ring. Use an absorbable suture like a 2:0 Vicryl. Amputate the sac distal to the suture. Before cutting the suture, observe the stump to ensure there is no bleeding. The ligated stump of peritoneum should retract up and out of sight, back into the abdominal cavity. Step 7. Repairing the posterior wall of the inguinal canal is the part of the operation that provides the long-term strength. Use interrupted simple sutures. Use a strong, non-absorbable suture, such as 0-proline or ethibond. The repair involves suturing the conjoined tendon, formed by the lower edges of the internal oblique and transversus abdominis muscles, above, to the iliopubic tract or the shelving edge of the inguinal ligament below. It is easy to accidentally start taking suture bites progressively more widely and more anterior on the inguinal ligament as you move laterally. This is a mistake. It creates a shallow, tense repair that is prone to recurrence. Every bite on the inferior side should be on the strong, deep shelving edge. Step 7 continued involves internal ring calibration. As you approach the lateral end of the repair, you will be reconstructing the internal ring. You must ensure the tip of your fifth finger can be inserted into the ring next to the cord. If the ring is too tight, it causes venous and lymphatic obstruction of the pampiniform plexus. It is often easiest to place all sutures first before tying them down. If the repair appears tense when you try to approximate the tissues, make a relaxing incision in the anterior rectus sheath, just above the pubic tubercle. This is a vertical incision in the aponeurosis that allows the upper flap to slide down, dramatically reducing tension on your repair. Step 8. Close the external oblique aponeurosis. This closure does not contribute to the strength of the hernia repair. Its purpose is to reconstitute the normal anatomy of the inguinal canal, which makes any future surgery in this area, hopefully not needed, much safer and easier. Carefully replace the cord structures and the ilioinguinal nerve back into their normal anatomical position within the canal. Close the external oblique aponeurosis with a continuous, simple suture using an absorbable material like 2:0 Vicryl. Warning: do not take large bites, as this just tears the aponeurosis. As you run this continuous suture, you must constantly visualize the ilioinguinal nerve to ensure you do not incorporate or trap it in your suture line. Entrapment of this nerve is another common cause of persistent postoperative neuralgia and pain. Step 9. Close the superficial fascia. Closing scarpa's fascia does not add strength, but it does reduce dead space, which can help minimize seroma formation and improve cosmetic appearance. Use continuous or interrupted absorbable sutures. Step 10. Close the skin. Close the skin with interrupted sutures, typically 3-0 or 4-0 nylon or proline. Alternatively, a subcuticular stitch or skin staples can be used. The approach for a direct hernia is similar to an indirect hernia but has key differences. You must always carefully explore the cord structures for a possible coincidental indirect hernia. Finding both a direct and an indirect hernia on the same side is called a pantaloon hernia. If you find only a direct hernia, there is no true peritoneal sac to ligate. The hernia bulge is a protrusion of preperitoneal fat through a weakness in the transversalis fascia. You simply reduce this bulge. The core of the direct hernia operation is the repair of the posterior wall. The weakened transversalis fascia in Hesselbach's triangle is reinforced by suturing the conjoined tendon to the inguinal ligament. Non-operative manual reduction technique is as follows. Position the patient supine in a slight head-down, Trendelenburg, position to relax the abdominal wall. Administer sedation or analgesia to reduce muscle guarding. Apply gentle, steady pressure on the hernia mass, guiding it towards the inguinal ring. If manual reduction fails, the patient requires urgent surgery. Preoperative preparation must include nasogastric tube placement for decompression, intravenous fluids to correct volume depletion and electrolyte imbalances from vomiting. If reduction is successful, admit patient for overnight observation to ensure no development of abdominal pain and arrange elective surgery. Let's discuss incarcerated hernia, which is a surgical emergency due to the risk of progression to strangulation and bowel necrosis. The most common tissues to incarcerate are the small bowel and omentum. Femoral hernias and indirect inguinal hernias in children have a particularly high risk of incarceration and strangulation. If the incarceration has been present for less than 3 hours, the risk of strangulation is small, and you can safely attempt manual reduction. You can then refer this patient for repair by a qualified surgeon. Do not attempt manual reduction of an incarcerated femoral hernia. The neck is so tight that the risk of reducing strangulated, non-viable bowel is unacceptably high. These patients should go straight to the operating room or be referred immediately. Do not attempt manual reduction if there are clinical signs of strangulation. The management of a tight hernia neck is necessary if the hernia neck is too tight to safely deliver the bowel for inspection. You can carefully incise the medial aspect of the internal ring superiorly to loosen it while avoiding the inferior epigastric vessels. Always have Babcock clamps on the bowel before releasing the neck, as the contents may retract uncontrollably into the abdomen. If a safe resection and anastomosis cannot be performed through the groin incision, you must not hesitate to proceed to a formal lower midline laparotomy. The patient's life depends on the removal of necrotic bowel. Managing doubtful bowel. If the bowel is dusky or cyanotic, cover it with moist, warm saline gauze and wait for 5 minutes. Reinspect. If the color has improved, becomes pinker, and you can see pulsations in the arcade vessels, the bowel is viable. Reduce it and complete the repair. If the bowel is not viable or is frankly gangrenous, a small bowel resection is necessary. This can often be performed through the groin incision, especially if the incarceration is at the external ring. If only the omentum is strangulated, suture ligate the necrotic portion and excise it. The most important step concerning sliding hernia is its recognition. Sliding hernias are present in 3 to 5% of cases and are more common in elderly men with long-standing hernias. They are often an inguinal scrotal hernia, which is one reason the inexperienced operator should refer these cases. Sliding hernias are often on the right side, involving the cecum. In a direct hernia, a sliding component is less critical as the sac is not ligated. You must suspect a sliding hernia when the sac appears unusually thick, fleshy, or difficult to mobilize completely. The initial steps for the sliding hernia are the same as a standard inguinal ligament repair up until you open the sac. Once you recognize the sliding organ, e.g. cecum, do not attempt to dissect it free completely from its mesentery, as this will devascularize it. Remove as much of the redundant peritoneal sac as possible without endangering the organ. Close the peritoneal edges with an absorbable suture. Then reduce the sac and proceed with the standard repair of the posterior wall and internal ring, which should still admit a fingertip. Femoral hernias can be diagnostically challenging. Sometimes it's obvious preoperatively. Other times, you discover it only during surgery for a suspected inguinal hernia. The femoral canal must be closed. A femoral hernia protrudes through the transversalis fascia, proceeds underneath the inguinal ligament, lateral to the lacunar ligament and medial to the femoral vein. The operative approach is through the same inguinal incision. After opening the inguinal canal and mobilizing the cord, you will see the hernia sac extending from below and deep to the inguinal ligament. The pectineal ligament repair is best done by an experienced hernia surgeon. Pectineal ligament repair. Due to the high risk of strangulation, you must control the sac contents before releasing the tight neck. Mobilize the sac. To release the neck, you may need to divide the inguinal ligament vertically at the level of the hernia. When you open the neck, the contents can disappear back into the abdomen instantly. You must have a Babcock clamp on the sac or its contents before you open the neck so the content or controlled. If the small bowel is strangulated, a bowel resection is needed, which can often be done through the groin. If not possible, proceed to laparotomy. After dealing with the contents, close the neck of the sac with a suture ligation. The posterior repair is performed using non-absorbable interrupted sutures. Suture the conjoined tendon down to the pectineal ligament, Cooper's ligament, which is a strong white line on the superior pubic ramus. This closes off the femoral canal. The transition stitch. As you place sutures laterally, you approach the femoral vein. You will need a transition stitch when you stop taking bites of the pectineal ligament and start taking bites of the inguinal ligament. If you continue placing deep sutures lateral to this point, you are in extreme danger of putting your needle through the femoral vein. Lateral to the femoral vein, you close the conjoined tendon to the inguinal ligament. A relaxing incision is necessary to reduce tension on this repair. Performing a relaxing incision. Elevate the upper leaf of the external oblique aponeurosis. Make a vertical incision in the fused aponeuroses of the internal oblique and transversus abdominis, the anterior rectus sheath. Start about 2 cm superior to the pubis and about 4 cm from the midline. Final point. There is no harm in making a relaxing incision for any tense repair, and some surgeons do it routinely to minimize recurrence risk. Pediatric repairs present unique difficulties which are usually best treated by a surgeon. The structures, vas deferens vessels, are very small and easily injured. Children are less cooperative, often requiring general anesthesia. The etiology is almost universally a patent processus vaginalis, indirect hernia. Therefore, the repair is vastly simpler. It consists only of high ligation of the indirect hernia sac. In older children, you may place a suture to close a widened internal ring. A complete repair of the posterior wall of the inguinal canal is not necessary in children under 16 to 19 years of age. Their native tissue is strong, and the defect is purely the patent sac. Apply your knowledge to some high-stakes scenarios. If you injure a loop of bowel, repair it immediately in 2 layers with an absorbable suture like 3:0 Vicryl for the inner layer and non-absorbable for the ceremuscular layer if needed. If your field fills with blood, you most likely have injured the inferior epigastric vessels, which may be ligated, but if you have injured the external iliac or femoral vessels, apply immediate direct pressure. Call for vascular surgical help immediately. Do not attempt blind clamping. If you cannot reduce an incarcerated indirect hernia, you must proceed to surgery or refer for surgery so that the sac is opened and the bowel is inspected. If you cannot reduce an incarcerated femoral hernia, take the patient straight to the OR for formal repair and bowel resection or urgently refer. We will briefly review the postoperative care of your patient. Immediately postoperatively, assuming that a local block was utilized, before patient discharge, assess the respiratory rate, oxygen saturation, and work of breathing. Position the patient safely, usually on the side if they are drowsy. Prescribe analgesics. Ask about bladder fullness, discomfort, or inability to urinate. Encourage movement. Inspect the surgical site and dressing for bleeding and swelling. 1 week post-op. Ask about overall recovery since discharge and whether pain is improving, stable, or worsening. Inspect incision for redness, swelling, warmth, drainage, or separation. Review lifting, driving, and work restrictions and encourage a gradual increase in activity. Assess bowel function, constipation, diarrhea, or nausea, and review fluid intake and diet. Prepare an operative note, document any complications, and provide written discharge instructions to the patient. Hernia repair is complex and requires practice. Start with simple indirect hernias in young men. Take the opportunity to do as many cases under supervision as possible. In this course, you will have the opportunity to practice on simulators and on patients. Review the slides provided in this module and the previous module until you have memorized all the critical anatomy and anesthetic pointers.